Oh, I have to press. Okay, yes. No, no, yeah, no. Thank you for that introduction. I think it's kind of correct. I will also talk a little bit about the differences between the approach that we take and and maybe Amsterdam. Although we do work together, everybody in this field kind of knows each other, of course. And so I guess one of the main differences is that we really focus on developing idiographic methods, which means, yeah, when you are a clinician in practice, you only have one person in front of you and not a random sample of thousands of people. And so, yeah, how far can we go basically using formal methods and theory also to develop methods that could potentially be used in practice? That's our main focus. And I think I'll talk about that a little bit. That let's say the statistical approach fails a little bit there, and attached to that is a whole story which I won't have time to go into, but there's a whole story about measurement. I'll briefly mention that, but that's why the subtitle is called "From Latent to Collective Variable." So we are really interested in working with, yeah, observable behavior and then making inferences based on that and not assuming that there's some kind of latent construct generating the data. Yeah, here we go. So I don't do this alone. As you can see, a lot of the studies that I will talk about have been done in collaboration with other universities, but also importantly with clinical practices, different ones also in Germany and Poland. So yeah, of course, we don't do this work alone. And we have an interesting group here called Complexity in Behavioral Science, in which we meet kind of bi-weekly, and it has sort of spread across the Netherlands, but also across the globe, because Matti also sometimes drops by and listens to what we have to say. And our shared interests are these idiographic methods, theory development, which means developing the complexity theory, and of course always with an eye on clinical practice. So we want to work on things that might actually in the future be applied in practice. So the structure is, I'll give a little bit of an idea. I'll talk about our reconceptualization of psychopathology, and actually a lot of people have been reconceptualizing this in terms of complexity science. And then I'll talk about some of our studies that we've done and give us, sort of evidence that we might be on the right track. And then I'll talk about, I guess, our best example of what this might lead to and how this is quite different from current practices, I think. And maybe talk a little bit about measurement theory. So why would we think about a reconceptualization of psychopathology? Well, we know, of course, that if you look, for example, at studies of depression, that there is some success there. At least people do get better, right? But yeah, you could question whether this is optimized currently, right? So if you look at the studies done by Kuipers, who really looks at there's a kind of meta-analysis of randomized control trials. So yeah, so he's really summarizing hundreds of studies, and the conclusion has been for several years now that 25 to 40% of patients actually benefit, which is defined as a reduction of 50% in symptoms. Over time, there's not a lot of improvement in terms of the effect sizes, so they remain small to moderate, and most people will need like 2 to 3 treatment programs before they actually report that they have improved. It is the case that we are helping people, but maybe if we look at these numbers, something could be improved, right? Another important problem that has gained more and more attention recently is the problem of the lack of group to individual generalizability. So most of our studies are based on large samples. we build statistical models, find relationships between all kinds of variables, but they are inferred at the level of the aggregate, at the level of the group. And for example, this study by Fischer is interesting in this context because they basically did both, right? So they had a large sample of patients with mood disorder, but they also had time series data in which they just monitored how people were feeling for a longer period of time. And so they calculated basically the correlations between variables really within persons based on those time series, but also based on the aggregate, so based on the whole sample. And they found quite substantial differences. And their conclusion here, well, this is their worst case scenario, is that that it threatens the veracity of countless studies, conclusions, and best practice recommendations. If you cannot use the aggregate inferences that you made to apply to individuals, which is basically what we try to do, of course, in clinical practice. And this is another study. The study below here is about a brain study in which basically they try to find, based on neuroanatomical model of the brain, differences between schizophrenic patients and healthy controls. And what they found was that at the level of the group, so if you compare the groups, you find different brain structures. So you find brain structures that you could use potentially to identify the patient group. But if you then take those structures and look in the individual patients, you don't find any any consistent results. So you can have results at the aggregate level that really don't apply to anyone in the group, it appears to be. So in this case, it was like less than 2% had the same abnormalities. And so these things, I'll skip this one. These things have led several people to think about what are we doing? Is that the right conceptualization, especially as it applies to psychopathology? And you get these types of statements by researchers claiming now that psychopathology is a phenomenon with a massively multifactorial etiology. Oh, I see there are questions being asked. Oh, you are. Okay. Let me know if there are any questions, right? Then
I'll monitor the chat and I'll let you know. I'll just drop some references there.
Okay, great. So, so this idea of the symptom networks was introduced by Bosboom and Kramer, and basically, I'll provide some more details. But basically, they say, we have all of these psychopathologies. They are characterized by an extremely complex set of factors that cause it, but also within individuals, these differences are very large. And this is exemplified by this study by Fried and Nesse. They looked in a very large sample at the different patterns of symptoms that individual patients had for depression. Right. So in the DSM, you have a whole group of symptoms that you should have like 10, or I don't know exactly what the criteria is, but they analyzed those patterns and they found that also like there were just very few common patterns. So it's a very large percentage actually shared the same pattern in that group, right? So it's not a consistent syndrome, and so then you get studies like this is like a sort of a review study which defines basically psychopathology as a complex system of contextualized dynamic processes that is non-trivially specific to each individual. It's a very nice definition, meaning that the different histories of individuals play a role in whether or not you will find someone to develop a psychopathology. And then this is basically our kind of definition in which we say that, the psychopathological state is a state that emerges in a complex system. And in that sense, it's not different from any other state. It's, when you're happy, that is also an emergent state of a complex system. But for some reason, there can be states that you would call maladaptive, or at least that the individual experiences this as something that is not very nice, let's say. But whether or not that is the case, whether or not you will call something a pathology, basically, is always a normative statement. It's always relative to the time frame that you're in, the culture that you're in, maybe even the age you have. Right? Kids can show behavior that we would never call pathological, but if you do it as an adult, maybe you would say that's not normal. But the key point is that it's always a normative statement, essentially. So it's not a traditional medical model. I'm putting medical model in between quotes because when psychologists talk about this, they have a really very basic conception. Of course, the medical model allows for very complex etiologies as well. But what they actually mean is that if you look at psychopathology, you really cannot identify something like a root cause, a pathogen, right? Like a virus that is responsible for the symptoms that we identify as belonging to this disease of psychopathology. Also interesting, symptoms are always both diagnostic criteria and its causes, which is kind of odd and not at all the same as most medical diseases, right? Like dyslexia, problems learning to read. When do you have it? Well, when you have problems learning to read. And what is it? Well, it's you have problems learning to read. There is no genetic test, no brain test that you can administer to determine whether someone has developmental dyslexia or not. You have to look at their reading performance. And that's what determines whether you have developmental dyslexia. And this holds for a lot of these psychopathologies, whether it's depression, mood disorder. They have this weird feature. So, and this is where the symptom network idea comes from. So, here in this in a set of papers, the group from Amsterdam really defined psychopathology as a network of symptoms. Symptoms can become activated. This can be different for different people. But when does something become a psychopathology? Well, when two symptoms become connected and start a feedback loop. Basically, one symptom will intensify the other one. A famous example is sleep. If you cannot sleep at night, you will feel miserable. And the next day, when you cannot sleep, you will start to ruminate. And because you're ruminating, your sleep even gets worse. So you get these feedback loops of different symptoms that maintain each other at some point. And these can be quite large. There can be many more feelings of fatigue. They can all become caught into this network of symptoms that then becomes automatically activated because, they have a feedback loop has emerged. That is the symptom network view of psychopathology. So also based on the idea of emergent from a complex system, there's an idea in there that it can be very specific to the individual. Not everybody will start sliding into a depressed state based on lack of sleep, for example, but it could be. So those are very promising and have been studied, I guess, for over a decade now. However, recently we see these papers coming out by the progenitors, basically, of the theory that are starting to question whether they are on the right track. Right? So, for example, Sascha Epskamp writes, network psychometrics may make concessions that make the models used deviate from the complex system thinking that inspired network theory, as an explanation of why we have not yet seen the translation from the network models basically to applications in practice that can be useful. There are a lot of things that are from complexity science that these symptom network models, as they are implemented currently, cannot do. For example, multi-scale dependencies, different time scales, or maybe different spatial scales that interact. And actually, when you look at the theory talks about feedback loops, but the statistical model doesn't really model feedback loops. It's a statistical model. And so if you would take a dynamic systems approach, then you can model feedback loops, but that would look very, very different from the way it's implemented. And then there's a problem with the person-specific um, uh, implementation in the sense that, most of these models require the data to be collected, and then you can analyze the data. But that's not what you would like to do in practice. You would like to monitor the data as it comes in, and then maybe make decisions about intervention or what to do as the data comes in, right? You cannot wait until you have everything and then run the model, because that's just not practical. Well, and then there's problems with interpreting network measures. So graph theory is assuming that like the nodes in the network are connected through some kind of maybe social connection, or an information flow, or traffic or something like that. But the correlation, that's not the same thing, right? So these network measures that are being used to interpret whether variables are correlated, you can question whether those actually mean the same thing as was intended in the original network theory. So our explanation of why this might, I'm not saying fail, but why they currently have problems, taking the next step towards maybe application in practice, is that we know that if you analyze these time series data of self-reported internal states, let's say, which is what you do when you ask someone, how do you feel today, on a scale of 1 to 10, we know that they violate all kinds of statistical assumptions. So there are regime shifts. You get differences in stationarity. You get differences in the variance that you see, and more importantly, for example, the autocorrelation function. So the correlation structure that exists in these time series is also different depending on at which part of the time series you look. And this table here is from a publication in which we basically looked for the stationarity of a whole bunch of different statistics. And I think almost all of the time series, so these are all measurements of one person who filled out these self-reports for, I think, 200 days or something like that. I think only I Feel Hungry would meet the assumptions that you need to fit a statistical model to it. And all the other psychological variables, they're non-stationary. They basically violate all the assumptions that you need to be able to fit a statistical model to it. And that's, of course, a problem. So our theory is published in I guess 2 papers. If you want to get the first one, you already get a nice picture, but the 2 of them I think belong together a little bit. So complexity theory of psychopathology, and there we really make like an ontological commitment, I would say, to the complex systems ontology. So it means, so what we try to do is, really, if we really believe that psychopathology is an emergent state of a complex system, what does that mean? So how do our definitions change? Do we need to change our methods? And if so, then we should do that. All right, we should not try to fit it into a statistical framework if that's not possible according to the theory. And so basically, so I'm not going to explain everything here, but basically the idea is that we have these attractor states that can have a different stability. At some point during the life of a person, a state might, like a depressed state, might emerge. But the mechanisms that make that state emerge are not different from any other state, like a happy state or a healthy state or things like that. So all the mechanisms of the emergence of the states, but also transitions between different states, they are basically the same. They are naive for what they actually represent. And so, we work from this idea that pathology is not a disorder, but it's just a different kind of order, and one that usually the individual who experiences it does not like and want to change. But usually they cannot do this just by themselves, so they need help with that. Also important is the commitment to an interaction-dominant causal ontology, which means that we assume that it is not possible at all to isolate neat components that you could call cause of this particular state. And it's basically always the case that there's a whole range or cascade of different causes that might also exist on different time scales and even maybe spatial scales. So if you make that ontological commitment, then you quickly realize that that you can look differently at what's going on during the therapeutic process. So suppose we can describe, so this is the ball and landscape metaphor, in which in this case we see two different states, an unhealthy phase and a healthy phase. So if the patient is in the unhealthy phase, depressed, what the therapeutic process is actually trying to do is it tries to destabilize the unhealthy state and make a more stable, healthy phase, and then tries to transition to that state. And this is a very general description of basically how complex systems change their behavior also. So this would be called in physics a phase transition. And here we call it a clinical transition due to the therapeutic process. And so there are different, it's interesting if you look at what therapies try to do, very often in sort of the protocols, you can see that, or at least we think we can recognize that this is actually, that this is what's going on, like a treatment for anxiety disorder, right? Works up to this exposure session. And the exposure session is really like a huge perturbation of the system, and perturbations can cause, for example, the ball to shift to another well in the landscape, and could lead to a change in the global state. So I'm going to skip this. So the main difference is that with traditional approaches is that we don't think there are components, unique causes that need to be fixed, to help people. No, we have to destabilize one state and then try to move the patient to a new state that is more desirable, right? So not thinking in terms of components, but thinking in terms of states that you can transition between. What is interesting that if you look at the theory in more general about complex systems, the transitions between two states are characterized by very interesting phenomena that you can actually observe, right? So before a transition takes place, we have this phenomenon of critical slowing down, which means that a lot of things in the system will become very strongly correlated and will basically go into the same direction. There will be critical fluctuations during the transition. And after the transition, there should be a phase where it's not so easy, at least if it worked, right? If you transition into another stable state, there should be resilience to perturbation. So there should be another new stable state should have emerged. And all these things are actually empirically accessible. So we can try to measure those things as they are going on. And of course, this is what physicists do all the time. This is the same as what happens if you boil some water on the stove, and first the water, seems quite stable, and then there's this critical point where it all of a sudden starts to boil, and that's this transition. Then around that transition, you can measure all these things, and that is what we have tried to do a whole bunch of studies. This is actually the first of these. It's just quite old, very small study, but it's very characteristic of the things that followed. In this case, we were interested in, or we were presented basically with a data set in which a parent and a child were following a therapy to treat antisocial behavior. So it was kind of a system approach where the parents were also involved, and they had a couple of sessions of video recordings where the child and the parent were sitting at the kitchen table, and they had to talk about just a regular topic. And then an alarm would go off, and they had to talk about something that caused stress, basically. And these video interactions, they were so that's what we would call a perturbation study, right? We're trying to explore the different phases that the system can go to. And these were analyzed in a behavioral sense. So behaviors were coded like the mom is aggressive or the child is passive, and the hypothesis was they couldn't. So the original people who collected the data could not figure out a relationship between people who really improved from the therapy and who didn't, and they had problems figuring out why some people improved and why others did not. And so we had the hypothesis, well, then maybe it's the case that the people who went through all these characteristics of this phase transition, maybe those are the improvers. And so in this case, we looked at time series analyses of these different sessions, and we looked for this characteristic pattern that is associated with the picture that I just showed you, right? Critical slowing down, critical fluctuations. Here you see the 6 sessions on this axis. And this is actually the result of kind of a time series clustering analysis in which we just said how many groups are in this data. And you can see that there's one group which has a peak, which is indicative of these critical fluctuations, and then a whole period where it's kind of stable. And this group actually is kind of doesn't show this critical doesn't show these critical fluctuations. And then, of course, the question is, was there any relationship between improvement and not? And that was the case. I mean, it's not perfect. It's also not a very large sample, but this was for us an indication that we might be onto something. So this group here was actually the one that contained the most improvers, and this one that contained the most non-improvers. And so that led us to at least gave us a hint that there might be something here. Especially important was that if you analyzed what the people were doing, because that was basically what led the original researchers of this result, they thought parents have to learn to be less strict. Maybe they get angry too much, and they have to become more empathetic to the needs of the child. But that's not at all the case. Some diets became more angry, some indeed became more empathetic. There was not really a clear pattern. So, but importantly, in the dynamics of their interactions, we did see this characteristic pattern, basically, that indicated a phase transition occurred. So basically, every diet took from the intervention what they needed. That was at least our conclusion. So then this led to a whole research program, which in the end led to much larger studies. And I think the most important one are these 2 studies. Especially the one at the bottom here. So critical fluctuations as early warning signals for sudden gains and losses. So this was done on a very large data set from a clinic in Germany and Austria, I think. Over 300 patients who were being treated for mood disorders. And they were following treatment inside the clinic, and every day they answered a whole battery of questions, which were basically all of these self-reports on their, let's say, their internal states. And what we were interested in is, can we now find also these indications of phase transitions in these time series, and is that associated with better outcomes? And one of the things is, so I mentioned that we already know that statistical summaries might not be the best way to look at these data. So the measure that we used here is called dynamic complexity. And to get an idea about what this means is, so if you compare, for example, this plot with this is obviously a different pattern, right? So suppose that these are ratings of, I feel happy today. Right here, all you see a sudden shift, and here it's actually, oscillating between extremes. But if you calculate the variance of these two plots, it's exactly the same. And the mean is also exactly the same. So using traditional aggregate statistics to characterize this difference, you will get nowhere. So dynamical complexity is something that measures actually the amount of fluctuation, so the fluctuation intensity, which is one of the things that is one of these characteristic properties of surrounding a phase transition. So here, this would yield different numbers in terms of dynamic complexity, and the same here. And so here you have, right, these are 1, 2, 3, 4, 5, 6, 7. This also, but it's in a different temporal order, and obviously there's more fluctuation here than in this one. So we want to be able to differentiate between these different patterns in the data, basically, and that requires different summaries. If you want to know how to calculate it, you can look at this slide, but let's not go there. So what you see here is data from one patient. This is the multivariate time series that they filled out during their treatment, 60 days here. And this is the problem intensity. So what you see here is that it starts out quite high, and then this is an improvement because the problem intensity goes down. And then here's another improvement. So these we would call sudden shifts that occur, and they might be described as phase transitions. And this, what you see here, is the dynamic complexity. So that's this measure that I just introduced. And you see just before the transition here, there's a peak in the fluctuation with which they answered these daily questions, right? So that could be a sign that there's some destabilization going on and a transition might be imminent. The same here you could argue it happens exactly at the same time, or this could be a peak. Well, at least there's a very large difference here. But yeah, that's the basic way that we try to analyze this data. So very large multivariate time series data set, and we try to look for critical fluctuations and see if that's somehow predictive to symptom reduction. So we had 328 patients. Of course, first we analyze it at the level of the individual, in the sense that we find out whether there were these sudden shifts in these could, by the way, also become worse, right? So the symptom intensity could also go up. And then we analyzed the whole sample in using a multi-level event occurrence, which is kind of a survival analysis. But maintaining each individual's gain and loss time series. So it was basically a series of zeros and ones, and one means then there is a transition here. And you can put that into these types of models. So it's kind of maximizing the idiographic approach. It's still a statistical model, but we've done our best to characterize each individual. So what we found was that it's indeed the case that looking at these peaks in critical fluctuations they are predictive of an imminent sudden gain or loss, which is interesting because, and that's something that we also expected to happen. Yeah, these fluctuations, they are naive to the content of the state, right? So going to to a worse state or going to a better state, the phenomena is indifferent to that. So we should see critical fluctuations either way, irrespective of which direction you take. But on average, 4 days after the observation of a peak in critical fluctuations, there was like a 50% increase of observing a gain or a loss. And that's so this I usually describe this as, absent the theory that points you to look to these critical fluctuations, that would be a very strange coincidence to find this, right? So this is kind of, for me at least, provides strong evidence that there might be something there. And of course, the subsequent studies are now being done actually that try to figure out whether if you know that there is this destabilization, if these critical fluctuations have been observed, can you then be more effective by focusing maybe an intervention in that period, right? So to make the transition quicker or smoother or in the direction that you want. But those are still open questions that we are looking into. Yeah, okay. Now let's go to the to the most extreme example or the best example that we have. So the studies that I talked about until now all use kind of standardized questionnaires for each patient. So each patient gets the same questions. But I already explained that yeah, there's so much difference, and if you really embrace the complexity theory, then this individual history of a patient should also matter, right? And so we had the chance to let me skip a number of things here because otherwise we cannot make it. Yeah. We obtained a data set from also a German clinic in Germany who were using a method called idiographic system modeling. And this is like an interview technique. So the therapist and the client, they interview, and the goal is to make a network like you see here. And this network is really completely only relevant to this client. And what it has to express is it has to express what are the kinds of things that make my symptoms worse, and what are the kinds of things that might alleviate them. And this network is then translated into questions, into a questionnaire. So there's a completely personalized questionnaire for this patient, and this is then administered every day and becomes part of the treatment process. Very interesting technique, but yeah, they said here we have over 400 unique multivariate time series. There were different questions, numbers of questions per patient, they had different lengths. Can you sort of show that our method works? So that was an interesting data analysis question. All right, so what we actually ended up doing is, yeah, looking to the theory again. So, yeah, complexity theory basically told us, yeah, if you have these high-dimensional systems that can be very uniquely dependent on the history of their evolution, basically, of their state evolution, what you can always do is look at dimension reduction techniques that try to basically find which components of the system are responsible for the most variance, basically, over time, which is, of course, leading you to techniques like principal component analysis. And so principal component analysis is conceptually, so it might look a lot like vector analysis, but conceptually it's very different because there's no measurement model there, right? It just divides, it looks into the data and then it tries to find out different components that are just defined as, yeah, that's where the most variance is located, basically, and the components are orthogonal, so they are in that sense kind of unique. So if you do that, so we had many different unique multivariate time series, unique for each individual patient, and we can then basically create a personalized representation of that multivariate data and analyze what is going on in that time series. Basically, it's a projection of the first principal component. So we had, yeah, 483 patients, and they had almost 5,000 unique concepts in these time series, in these questionnaires. And again, very unique. So 87% was just mentioned by one patient. So this is really personalized monitoring. Interestingly, we talked about this idea of the symptom networks. If you do a thematic analysis, qualitative analysis of what kind of themes do people mention, almost no symptoms. They're all psychological, autonomy, emotion, connectedness, self-care, identity. There are the symptoms of the symptom networks. They don't appear here, which is kind of interesting. So yeah, maybe that's also a conceptualization that is not entirely representative of what is actually going on in psychopathology. So we analyzed these data by doing PCA and then projecting the first component. So every patient had one time series now, which was a summary, basically, a representation of, let's say, the most important dimensions of this multivariate time series. Yeah, we found a number of different patterns. So one of them was the transition, and this actually occurred most. So most of the projections of the of the PCA had one transition. That's how we started to call it. There were also no shift. There was gradual change and also multiple shifts or reverse shifts. But I think like out of the 480, I think these two represent almost 300 patients. Right, so these were much less common. And yeah, what we then try to do is look at the outcome, because there were outcome measures of therapy success, and whether they were associated with one of these patterns. And yeah, again, it was, oh, here we have the numbers. 233 had one shift, yeah, and then multiple shifts, 25, so about 300. And then yeah, it turns out that especially having one shift was related to better treatment outcome. And how can you think of this? Well, here is an example of one person. So this person had this shift here, and this shift was caused by these questions in their multivariate personalized questionnaire. So to be in the here and now, have I shown feelings? Do I accept attention from others? So that was for this person. So you can still go back to the questions that were most important for the transition for this participant, which is very interesting. And I don't know what exactly the size of the whole time series was, but the likely in the 20 questions. But these were the most important ones. Now, this is actually a technique or a conceptualization that is also commonly used in physics, and that's the idea of the collective variable. So this set of questions, this set of completely personalized questions, they offer basically not a window into kind of the true things that go on, because sometimes people have very strange questions. They say something like, today I had to check my head cinema. I don't know what that means. Or, I had to empty my bucket. I can imagine something, but I don't know exactly what it means. But the most important thing is that it means something to this person, and this question, or at least the dynamics attached, give you a window into the actual internal state dynamics that are going on, right? And that's basically what we were trying to show. It doesn't really matter what you ask, but you have to ask something that is idiosyncratic to the person, specific to the person, and provides you a window onto these dynamics. Because in the dynamics, again, the content is not important, so it's dynamics over content. That's where the important information is that allows you to see these transitions that might be imminent or not. And so in physics, they do much more advanced things than using PCA. And that's also one of the things that we are now working on. So looking at these deep neural network methods, or maybe looking at other machine learning methods to find these collective variables. And they are present in manifest data. So we're not inferring something from the data, but we're trying to basically to figure out which representation of the manifest data gives us the best collective variable, which is, again, conceptually a bit different from latent approach. Let's see. What can I say very quickly about measurement in 1 minute? Yeah, basically the conclusion that one of the things that we run into, so we have a lot of experience working with youth in residential care, and these are youth that have had like really unique and yeah, terrible, let's say, histories that you really cannot imagine. So my experience with those stories really made me realize that it's really useless to try to come up with one question that applies to everyone, right? These histories are so unique, you really cannot imagine it. And so that this led to the idea, yeah, we have to find a different measurement theory that doesn't assume that you're sort of discovering a true score that is just covered by some random measurement error. And this is an attempt to do this. So basically, the idea is that we should just accept that everything that we do interacts with what you want to measure, and that's fine. It has consequences. There are some things that you cannot do anymore, but there are also things that you can do, like I showed you, right? You can just ask questions that at least tap into some of the important dynamics. And that's basically the goal of this whole project, which is not that different from modern physical theories of measurement, in which they also do this, right? So if you want to know the temperature of the glass of water, if the thermometer was freezing, was like at -10, and you put in the thermometer and wait a bit, what has happened there? So if you read out the temperature, is that a property of the water? No, it's a property of the measurement, because the thermometer cooled down the water, or maybe the water heated up the thermometer, but you cannot attribute it to the instrument, and you cannot attribute it to it's really an attribute of the measurement process. And that's I think a potential good way to try to think about what we do when we administer these self-reports. I will skip this. Let's see if there's something here that yeah, so we are measuring collective variables. And the important information that is contained in these variables is in the dynamics and not in the absolute values. So we also don't have to be too concerned with why did you say yesterday is 6 and now is 7, you know? But as long as the dynamics are consistent, let's say. Yeah, take home messages. So I think it's at least for me, what has helped is to really try to be commit to the ontology of complex systems, right? And not say, oh, maybe we can do this because then we can fit this statistical model. No, if you cannot, if a theory says you can do it, then try to find something else. And there's lots of things to find, as I hope I showed you. So interaction dominant dynamics is one of the dominated dynamics is important. Yeah, there's no privileged scale at which causality resides. I would say there's also no specific component where causality resides. It's usually a product of interactions. Dynamics over content, well, we talked about that. If you want to aggregate, try to stay as close as possible to the individual level. Yeah, and all measurement is interaction. And we're measuring collective variables. I think those are my take-home messages. Thank you.